You enjoy this topic?
Of course.
Why?
Of course, I like all topics.
I know you're gonna say that. Okay, so let's chat about diabetes and pregnancy.
Diabetes is the most common medical complication of pregnancy. Patients can be separated into those who are known to have diabetes prior to pregnancy, that is overt diabetes, and those diagnosed during pregnancy, that is gestational diabetes. 90% of all pregnancies complicated by diabetes are due to gestational diabetes.
So that means most women that get pregnant are not diabetic.
Earlier, before pre-insulin era, that was a problem, infertility. But now with the development of insulin and adequate control, pregnancy...
So we're seeing more pregnant women with chronic diabetes.
yeah.
What's the incidence?
Incidence was 2 to 3% earlier, previously, but in today's modern world, it has increased to 10 to 15% of pregnancies being affected by diabetes.
You think that's related to our lifestyle?
Yeah, obviously.
Obviously. Okay.
Gestational diabetes. Definition. Carbohydrate intolerance of variable severity with onset or first recognized during pregnancy and typically subsides within 6 weeks postpartum. Significance of gestational diabetes. If uncontrolled, is associated with increased perinatal mortality and morbidity. Early detection and control can lower the risk of mortality and morbidity to normal range, hence the importance of screening. These women are at significantly increased risk for subsequent development of diabetes mellitus later in life. Nearly 63% of women affected by GDM later on develop established diabetes at some point in their lives, usually within 16 to 25 years. Ultimately, gestational diabetes has short-term complications throughout the pregnancy and a long-term complication on maternal health. Short-term complications for the fetus, that is.
Hence, we should
Do screening.
and
Diagnosis for diabetes during pregnancy is most critical. Long-term close follow-up of the patient is essential due to potential long-term effects on the established diabetes. Perinatal mortality in diabetes is high because of congenital anomalies, that is gastrointestinal anomalies, CNS disorders, LS ratio in lungs not properly formed, sudden intrauterine death, macrosomia causing birth trauma, severe PIH, placental insufficiency, abruptio placentae. Neonatal deaths are high due to fetal RDS, hypoglycemia, hypocalcemia, and hyperbilirubinemia. In patients with established diabetes mellitus before pregnancy, there is still a high incidence of congenital anomalies despite good glycemic control. The main reason being the unpredictable periconceptional control of glucose. This is due to epigenetic factors at play during conception. If this factor of congenital anomalies is removed, then fetal loss in controlled diabetes mellitus is almost the same as in normal pregnancy, except in a few instances where deaths are due to macrosomia and sudden IUD.
so the difficult part is that most of the congenital anomalies are already formed by the time a woman finds out she's pregnant, right? And there's little we can do to control her sugars at that point in time. That's why Identification of diabetes outside of pregnancy is so important. And periconception, glucose control. You have some fertility patients you see. You automatically do a hemoglobin A1C on all of them?
Not in all.
Huh.
The high risk cases, like family history and
Symptoms of
big
diabetes.
babies, like that. It's not commonly available in all laboratories. So we restrict.
I think it is now. HB1C.
HbA1c, yes, when I was
When you were
practicing,
it was more difficult.
it was a little more difficult because I was in government hospital.
Right.
In private sectors, I have not seen many people doing this.
I think here at this hospital we can do it downstairs.
Ready?
Because they have the automated machines now.
Oh,
They're not doing blood
that's
estimations
good,
by
that's
hand.
good.
Yeah. Okay. What's the incidence of congenital anomalies in gestational diabetes?
Incidence is definitely as in normal pregnancy, with normal glucose tolerance, develops only in later pregnancy. The preconception values are invariably normal. This is the reason parental mortality rate can be brought to normal in GDM, but not in established diabetes mellitus mothers.
So sometimes we can group gestational diabetic and chronic diabetes mothers together, but sometimes in this category we can't, right? The risk for congenital anomalies is not increased with gestationally diagnosed diabetes.
Well,
Correct? So women who develop gestational diabetes around 24 to 28 weeks are not at increased risk for congenital anomalies. Only those mothers who have diabetes prior to pregnancy have increased risk. Correct?
yeah, because we don't know when they conceive.
Right.
Or what was the glycemic control that time, we don't
Right.
know.
Right.
So it can be high.
Who do we screen for diabetes in pregnancy?
In fact, every universal screening.
Universal screening.
The area of for discussion revolves around whether screening should be universal or based on risk factors. What is the screening test? What is the diagnostic test? The screening test is performed to identify the population at high risk for having a certain condition like diabetes. In that respect, a screening test differs from a diagnostic test, which identifies persons who actually have the condition rather than simply being at high risk for it. The earliest and simplest screening for gestational diabetes is history taking. The condition was first described in 1946 through historical term. The historic risk factors include, but are not limited to, family history of large babies, adverse obstetric history, additional criteria age above 25 years, and increased BMI are considered.
And it had a 56% sensitivity rate in detecting diabetes. That's pretty good for a non invasive test, no? History taking is very important for identification of risk factors.
The low risk group consists of age below 25, appropriate BMI, no history of fetal anomalies or large babies in family, no family history of diabetes, and those who do not belong to a racial group where diabetes was high.
I want to have a discussion about race in diabetes prevalence. Right? Which races have a higher incidence of diabetes?
Racial?
Is Indian ethnicity increased your rate for diabetes?
Of course, India has high incidence.
Diet or genetic factors? Or both?
Diet is the most contributor. Environmental factors mainly. And stress and strain precipitate diabetes.
But people are stressed and strained around the world.
Yeah, but in India, incidence is pretty high.
Right. Do you think it's related to the high, 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 high,
And they're sedentary now.
Yeah. Used to be not so, now yes. Now sedentary lifestyle is common in India.
Very common. Earlier they were very hardworking. They go to the fields and work. Now, no, they're in front of the TVs.
Sorry for that.
So insulin diabetes is increasing. Almost every year, almost all the members are diabetic only.
Okay. So, who to screen?
Population at large must be screened. Screening factors were found in 64% of women diagnosed with GDM. The remaining 36%, there were no risk factors found, meaning diagnosis is likely to be missed without universal screening. Timing for screening. First visit, that's first trimester. Recommendations vary from
The recommendations vary for which type of screening to use in the first trimester, right? Some providers perform hemoglobin H1C and fasting glucose in the first trimester, but if the patient's at high risk for development of GDM, an early 1 hour GCT is indicated.
But that point I don't know. I mean, first visit. But that I don't know. Some providers perform HbA1c and fasting glucose in the first trimester. That I don't know. I have not done that. I don't know where you got this from. You're convinced?
They do it here.
What did they do? Tell me.
They do an hemoglobin A1C and fasting glucose in the first trimester for some patients. Okay, but let's keep moving on. We're recording. Okay. If a patient has high risk for development of GDM, an early 1 hour GCT is indicated. Right? We don't do 1 hour GCTs on everybody. Right?
Everybody will do.
So we don't do
Abnormal.
1 hour GCT screening tests on everybody in the first trimester. Only high risk individuals.
High risk, of course.
But sometimes routine blood testing includes a hemoglobin A1C and a fasting blood glucose in the first trimester for some hospitals, some providers.
Maybe. I don't know.
Yeah, so your practice is different, right? Okay, so
Fasting glucose and GCT.
no, Dr. Hema. Some providers perform hemoglobin A1C and a fasting glucose in the first trimester. That's their early screening test. Okay, sometimes they do universal screening on everyone in the first trimester that way. For high risk individuals, they do 1 hour GCT screening test. So let's say Priyanka comes in. Okay, she's 12 weeks pregnant. Okay, she has a family history of diabetes. Right, that's her only risk factors, and she's Indian. Okay, family history of diabetes, and she's Indian. Her normal blood panel, she could take a CBC, STI testing, blood typing, all of that. Sometimes they also include a hemoglobin A1C and a fasting glucose if we're testing her blood anyways. Okay, if her risk factors are, I think it's 2 or more, 3 or more, that indicates an early 1 hour GCT
The
screening.
HbA1c is for what?
HbA1c is
HbA
a
for
snapshot into
abnormalities.
for glucose metabolism. It's a snapshot. Remember, hemoglobin A1C looks at the past 120 days.
Correct.
Yeah.
That's right. That is to know whether pre-pregnancy they had high level or what.
Exactly. And then the fasting glucose to see how their glucose is doing in this moment. And if that's elevated, then they move on to the screening test, 1 hour GCT. Okay. All right. So that's the first step. First trimester screening can be done for high risk individuals. Okay. And then what's the second trimester screening?
24 to 28 weeks screening. 1 hour GCT, oral glucose load of 50 grams, then estimate blood glucose after 1 hour. This is O'Sullivan's. Diagnostic test, 100 grams oral glucose, 3-hour GTT with fasting serum blood glucose more than 90,
Less than 90.
less than 90. Less than 90, correct.
The 1 hour.
1 hour,
Serum blood glucose is less than normal
120.
ranges. Less than 165.
less than 165.
The 2 hour normal is less than 145. And the 3 hour is less than 125. Right? In order for diagnosis to be confirmed, 2 values must be equal or higher than the normal range. Okay. But we forgot to say the normal range for the 1 hour is less than 130. Right? And so only if they fail the screening test do they go on to the diagnostic test. Not everyone has to do the 3 hour. So in your practice, what would you do that's unique? You would repeat the GCT at 39 weeks for those who had abnormal levels of the GCT at 24 to 28 weeks. And you've been very happy with this assessment protocol as you believe it truly confirms whether someone has gestational diabetes and proper precaution can be taken during labor, birth with a neonate, and postpartum. You know, that's the first time I heard of that. And then I think the internet was, sometimes the internet hears what we're talking about and then pops up with advertisements or articles, right? I was reading something and it said the only way to be 100% sure someone does not have gestational diabetes is to do a screening test at 39 weeks. Dr. Hirma said that. But it's not common practice.
It's not common.
No, but you do it on the ones that failed the 1 hour, but did okay for the 3 hour, just to confirm. But on a lot of...
Because I'm obsessed with this diabetes. Incidence is so high.
You heard that here first, folks. Dr. Hirmath is obsessed with diabetes.
Because the incidence is so high, no?
What do you think the incidence is right now of diabetes in general in India? Right, in 2025. What do you want to guess? Not just pregnant women, but the incidence in general.
No, I can't guess.
Incidence. You can't guess?
Can't.
Of diabetes in India. Okay, ready? It's not showing percentage. Okay. Well, that has a weird... Here's an interesting way of looking at it. 1 in 4 people in the world with diabetes is from India.
Then
So around the world, the people have diabetes. 1 in 4 is from India.
it's high incidence.
That's fine, but that's a weird way of thinking about incidence. Okay, so also, no matter what, anyone diagnosed with gestational diabetes has to be rescreened at 6 weeks postpartum.
That is to
Ensure that they haven't developed chronic diabetes or that it's not pre-existing.
it's not pre-existing.
Right. Okay. But a lot of women are lost to follow-up. Here in this hospital, we see them at 4 weeks, and then they don't come back.
That's common.
In the United States, our postpartum visit schedule was 2 weeks, 4 weeks, 6 weeks, because women need some support after birth. In Europe, the midwives do home visits, so it's easier. Because here there's the cultural norm that they stay at home for 40 days, right? So we have to work with whatever they're comfortable with. So, what to do? At home, 6-week GCTs. That can be your new job.
They can get blood sugars done at home only.
Yeah, they could do. They won't.
But if they understand the complications of not doing,
Right.
they will do.
Sometimes. But this is also an important factor though. If we know someone had GDM in a prior pregnancy, they're at increased risk for GDM in this pregnancy. Right. And we should assess them early in their pregnancy. Or even if they're trying to conceive, make sure their sugars are under control. So peri-conception, we can do one as well.
Breast conception
The
control is most important.
HbA1c only.
HbA1c, yes. It will predict over the last 3 months.
Yeah. And it could be diagnostic for diabetes outside of pregnancy, HbA1c. Okay. Anyways, what complications do you expect in an established diabetic woman during pregnancy?
Several complications of pregnancy, though not unique to the diabetic patient, develop more often in diabetic mothers than non-normal pregnancies. For example, preeclampsia is fourfold increased frequency in diabetic patients, causes related to vasculopathy. And next, infections, especially wound, urinary tract infection. Pyelonephritis is 6% compared to 2% incidence in non-diabetic. Polyhydramnios more common than polyhydramnios. Intrauterine growth restriction and subsequent oligohydramnios.
But polyhydramnios is the more common hydramnios.
Yeah, because of increased hyperglycemia and increased urine of the fetus. Congenital anomalies, neural tube defects, anencephaly, omphalocele. Congenital anomalies, neural tube defects, fetal hyperglycemia in utero leads to increased polyuria, so increased amniotic fluid, so polyhydramnios. Maternal PPH because of uterine overdistension due to polyhydramnios and macrosomia. Fetal proliferative retinopathy results in blindness and photocoagulation. Class H patients, pregnant patients with heart problems, with diabetic conditions in pregnancy, are the group at highest risk of maternal mortality and morbidity, and development of coronary artery disease in affected patients remains unknown. In the absence of arteriosclerotic disease, maternal mortality in diabetic patients is infrequent, particularly in the pre-insulin era.
So in the absence of arteriosclerotic disease, maternal mortality in diabetic patients is infrequent. Particularly in the pre-insulin era, the increased risk to maternal well-being presented by proliferative retinopathy, renal factor, or severe coronary artery disease makes patients with this disorder a candidate for therapeutic abortion and comprehensive family planning. So prior to the development of insulin, a lot of women with diabetes were counseled not to conceive, right? Because the likelihood that they could have fetuses with congenital anomalies and subsequent issues. But now that we're post-insulin era, women usually have their blood sugars under control and can conceive safely.
Diabetic ketoacidosis. The bicarbonate concentration in normal pregnancy is reduced compared to non-pregnant because of loss of CO2 that accompanies hyperventilation. Thus, ketoacidosis is as a result of maternal hyperglycemia develops the bicarbonate concentration is more markedly reduced in the pregnant than in the non-pregnant patient, resulting in the same acidotic insult.
So diabetic ketoacidosis is dangerous to mom and to baby. It's a complication, right?
Yeah,
Another complication.
preterm labor.
Now, what's the pathophysiologic reasoning behind diabetes influencing preterm labor? Is it polyhydramnios? Hydramnios only. Okay, now the question that everyone's been waiting for: how do we treat diabetes during antenatal, intranatal, and postnatal periods?
The aims of treatment will be achieving a metabolic state present in normal pregnancy. Second, avoiding iatrogenic prematurity. Third, detecting intrauterine distress before the fetal demise occurs, most likely due to excessive chronic maternal hyperglycemia.
And the fourth aim of treatment?
What is
the fourth aim of treatment? Eliminating maternal complications, right?
What is the
The fourth one.
eliminating maternal complications? What is the problem for metabolic control? Urine sugar is unreliable due to decreased renal threshold during pregnancy. Frequent blood sugar estimations historically was recommended twice a week. The current recommendation is daily or more. Home
GRBS monitoring with an at-home glucometer.
GRBS is what?
Blood sugar. Finger pokes. GRBS.
What does G stand for?
It's a good question. You want to guess? General random blood sugar. That's not a very good acronym. General random. Whatever. So you have it here, guys. GRBS means
I
general
was wondering
random.
what is that?
But that's what they call it here. GRBS.
Here, eh?
Huh.
This hospital.
Huh. But they call it that all over too. GRBS.
Is it there in the?
In the United States, we call it blood glucose.
Oh, that's a good. But what is this GRBS? I've never heard.
General random blood sugar.
Random blood sugar, general, performing on everybody.
Yeah, but they have they say go get the patient's GRBS, so they take the glucometer because GRBS is different than fasting blood sugar, serum glucose, right? Because GRBS is just
That
finger poke.
abbreviation is there in
Apparatus?
your mobile.
What?
The GRBS term is there.
No, I can't test my blood sugar with my mobile.
Oh, GRBS, that word is there.
General random blood sugar.
Oh,
GRBS.
I've not heard of it at all.
Or it says now this one says glucose random blood sugar. That one says general random blood sugar. This one says gamma ray burst, but that's when talking about physics. Difference between fasting blood sugar and let's see. Okay. FBS is fasting blood sugar, RBS is random blood sugar, and GRBS is general random blood sugar.
General, why that term general is put there? I can't.
I don't know. The random blood sugar and general random blood sugar is the same thing.
Same thing.
Yeah. Whatever. Okay, we digress. Next. So
Tight metabolic control causes hypoglycemic episodes, which are dangerous to the fetus. The optimal therapy is that which achieves a reasonable glycemic control without precipitating hypoglycemia, defined as plasma glucose below 60. That's a hypoglycemia is defined as plasma level below
in
60.
an adult.
The goal range for plasma glucose level is between 90 to 150. The other problem is increased incidence of ketoacidosis, so check urine ketones once weekly during pregnancy. Determination of glycohemoglobin levels HbA1c may prove useful as an independent check for the accuracy of self-monitoring blood glucose and glucose estimation in early pregnancy, therefore reducing the risk of congenital anomalies and perinatal mortality. However, real-time measurement of glycohemoglobin levels through GRBS testing is a more accurate tool to determine maternal glucose status later in pregnancy. HbA1c may not be a reliable indicator for glycemic control during pregnancy as there is reduced erythrocyte lifespan from 120 days to 90 days and increased erythropoietin production. HbA1c values typically decline by 12 to 16 weeks of gestation, plateau by 20 to 24 weeks, and rise again in the third trimester. Metabolic changes in normal pregnancy. Metabolic adaptations to provide glucose, the main form of fuel for the fetus. Glucose is also crucial to the transfer of alanine, an important amino acid in pregnancy, across the placenta. Carbohydrate metabolism in early pregnancy, that is before 20 weeks, metabolism
So
up to 20 weeks, it is diabetogenic,
anabolic.
anabolic.
Okay, so in anabolic metabolization before 40 weeks, a hormone alteration in a normal pregnancy is that estrogen and progesterone increase. Causing increased glycogen storage and decreased hepatic glucose production so that it can save sugar for the baby. This results in beta cell hyperplasia, causing insulin secretion to increase. Okay? This increases peripheral glucose utilization and fasting plasma glucose decreases, which results in hypoglycemia. Okay, so hypoglycemia is normal in early pregnancy.
No, you should avoid that. So that is the dangerous point.
So estrogen and progesterone increase. The normal pregnancy hormones increase. This causes increased glycogen storage and decreased hepatic glucose production.
Yeah.
So the beta cells get bigger, causing increased insulin.
And that will increase peripheral glucose utilization.
Because to give the baby all the sugar, right? We don't want to digest the sugar in mom's body. We want to give baby the glucose. So baby's getting glucose and mom is in a hypoglycemic state, anabolic state, right? Therefore, her fasting plasma glucose decreases because the sugar is going to the baby and not to her, right?
Yeah.
Okay. So then, after 20 weeks, what happens? Carbohydrate metabolism in later pregnancy.
Is diabetogenic
Huh.
because of hormonal changes.
Right.
Human chorionic somatotropin
Increases,
increases,
causing diabetegenesis. So raised blood sugar. Raised blood sugar increases. Then what happens to glucose tolerance?
decreases glucose tolerance.
Okay.
Accelerated anabolism during fasting.
Okay. So then she has more sugar when she's fasting. Okay. And then also in the second half of pregnancy, there's increased prolactin, which results in
Insulin resistance and accelerated starvation during fasting ensures glucose and amino acids to the fetus. Hyperglycemic state.
okay, and also there's increased cortisol, which causes
Reduces hepatic glycogen stores. Increased hepatic glucose production.
So this is in normal pregnancy. This is what happens. So when woman is diabetic or develops gestational diabetes, these processes get altered, right? Okay. It's a complex process to make sure the baby gets fed. So,
In genetically predisposed individuals, pregnancy is the best test for diabetes. Changes also occur in protein and fat metabolism. Classification of glucose intolerance in pregnancy. Type 1 is insulin dependent diabetes. This can occur at any age, common in young and most likely genetic. This condition is ketosis prone. Type 2 non-insulin dependent diabetes mellitus, onset in maturity. Genetic predisposition, ketosis uncommon, majority are overweight. Typically the onset of this type is after childbearing. Then the third one is gestational diabetes. Lastly, secondary diabetes secondary to other diseases. Overall strategy for diabetic detecting and managing GDM is as follows. Screen all patients with 50 grams glucose at 24 to 26 weeks. Use 3-hour oral glucose test when screening test result is abnormal, that is more than 130. When GDM is diagnosed, counsel on diet and lifestyle changes. Offer prophylactic metformin or insulin for fetal weight, weekly blood glucose profile, fasting and 2-hour postprandial glucose levels after fasting, after breakfast and lunch.
They no longer recommend prophylactic metformin or insulin anymore unless the 3-hour GCT is way, or GTT is way out of range, right? We'll give them time to adjust their lifestyle. How long do lifestyle changes typically take to impact glucose levels?
For example, more activity they should be advised.
Right, but how long? So, like, let's say their blood sugars were
Uncontrolled.
Uncontrolled, and they start a regimen, exercise, 30 minutes exercise every day, and they're cutting back their carbohydrate intake. How many weeks will it take for their sugars to get normalized?
Every 3 days it changes, no?
Every 3 days.
So 3 days we have a check.
We give them 3 days.
Yeah, only 3 days. And then we should see.
But I think most likely it's people have a hard time committing to lifestyle changes. Right? I think a lot of people would rather just take the medication and continue to eat what they want and not exercise.
But they should be convinced, they should be told about the complications. Then if they are convinced, they will go.
You have to teach me your therapeutic communication with patients. Therapeutic communication. Your therapeutic communication is do this or go out.
Now with obstetric patients, I think we have to be strict only. Not if we are mild and passionate, they overtake us.
The next consideration for managing GDM is
Prophylactic insulin.
yeah. Well, prophylactic insulin and metformin is no longer routinely done, case by case basis. But if after lifestyle changes, their blood sugars are still not in control, what do we do?
Add therapeutic metformin, but I have never practiced. And or insulin or increased dosage if FBS is more than 100 or 2-hour postprandial more than 120.
How many, we used to say if over 30% of the values they were taking, because we used to have women who were diagnosed with gestational diabetes test their blood sugar every day, three times a day. And if 30% or more of the values were abnormal, then we changed the plan of course. If under 30% were abnormal, then they're fine. Because some days they'll have a bad day, they ate something, they shouldn't be penalized. But if over 30%, that's a trend, over 30%, they have to take the next course of action, whether that's increased insulin or whatever. Is that what you would do too?
No.
What would you do?
I don't, we don't adhere to this criteria of 30% increase, all that.
Not 30% increase. If 30% of values were above normal range.
Because we never did blood sugar so often there.
I see.
Government
It was
hospital.
random. And you just had to kind of do a blanket because you don't know if they'd come back or not. I understand. Different patient population. Okay. And if even after we try metformin and insulin dosage we're comfortable with, their sugars are too high, what do we do next?
This patient is referred to an endocrinologist if unable to control GRBS with moderate insulin dosages. Use weekly NST for fetal surveillance beginning at 36 weeks. Now, I never refer to any endocrinologist because they don't know the changes in pregnancy and
Well, they should know.
they don't know. They don't know. At least physicians there in government hospital never knew, and they would unnecessarily, even if the blood sugars were little high, they would put on insulin and all. So I never used to refer to any physician.
So
I only would manage.
you would, but some insulin gets high. No? So I'm not comfortable prescribing high doses of insulin. I'm not comfortable prescribing insulin at all.
No.
Midwives, it's not scope their practice, but for you, if a woman's not responding well to insulin,
We go on increasing. Titrate. And at what level we get control, we should see, and then continue that.
but aren't you nervous? If it gets too high, they're gonna have a drop. If they don't, so we're doing it based on their eating trends. And I guess here in India, people eat the same thing every day. There's not a lot of variation. United States, people are eating different things every day. So maybe they had something carb heavy for dinner last night. Does not mean they're gonna have something carb heavy for dinner tonight. And so I get nervous with blanket high doses of insulin that would cause a lot of hypoglycemia. But here, you're right. People are eating the same thing for dinner. Roti sabji, rice sambal. Roti sabji, rice sambal. Roti sabji, rice sambal. Same. So their sugars are likely to be maintained. There's not a high risk for hypoglycemic episodes.
No.
Wow. Interesting. I didn't think about that before. How important the cultural tradition of what you eat
Yeah,
is.
they should actually eating should be uniform.
Huh.
Not changes should not be made so often. Uniform.
I like to eat the rainbow. Okay. So you're using weekly NST for fetal prevalence starting at 36 weeks because we're trying to prevent intrauterine fetal demise, fetal compromise. No. If her diabetes is uncontrolled or other complications arise, NST can be done by
more frequently.
Yeah.
Is not an indication for LSCS.
Diabetes is not an
Per se.
indication. You heard this now from an Indian obstetrician. Diabetes is not an indication directly for an LSCS. No.
But macrosemia may contribute. Use ultrasound for fetal weight estimation near term. Growth scan should be observed.
What do we know about fetal weight estimation by ultrasound? It's not 100% accurate.
No, I used to do clinical only. Clinical test I used to do
What?
fetal weight.
Huh, you're touching. Yeah, that's the second best. First best is mom's perception. But they have to have had a baby before to compare it. But usually mom's perception, what we're taught, mom's perception is the first best guess. Hands-on is the second best guess. Third is ultrasound. But I've noticed a lot of doctors here won't put their hands on the belly.
They
They'll
don't.
do Doppler, they'll do ultrasound.
Only that.
But they won't touch the belly. Why?
Nowhere they touch,
I don't understand.
Even gynec cases, to do they don't get up and do PVs.
They don't do abdominal palpation?
Nothing they do.
Why? They're not taught or they're just,
Not taught, no, they're so lazy.
they think technology is better?
Not that way. They're lazy.
Sorry.
Laziness.
But patient comes in expects to be assessed appropriately. They're not assessed. So what can we do? Okay. Anyways, during labor, how do we manage diabetes?
Monitor for that random blood sugar and FHR during labor. Administer insulin according to JRBS status.
So we're no longer going to do their normal insulin regimen. We're dosing based on actual GRBS because in labor,
Hyperventilation.
yeah, hypoglycemia. I was going to say something else. Oh, also having diabetes puts you in a high risk category, right? So FHS monitoring more closely, more frequently, even maybe continuous monitoring.
A continuous fetal heart rate monitoring. Elective LSS for primary gravida estimated fetal weight over a certain threshold.
What's the threshold? 5,000 grams?
No, 4.4 kgs.
4 kg.
4,000 grams.
For diabetic moms. For non-diabetic moms, it's 4,500 based on macrosomia. In the United States, it's 4,500 for diabetic, 5,000 for non-diabetic.
Continuous infusion of 5% glucose to all gestational diabetes in labor to avoid ketosis and to provide fuel for the work involved with labor and birth, continuous monitoring of FHR, and uterine activity throughout labor. Historically, prophylactic insulin administration was occasionally used for women that are not hyperglycemic enough to reduce the incidence of macrosomia.
We no longer do that.
In our
I wanted to ask one more question. I forgot what it was. Oh, why is there a difference between estimated fetal weight for diabetic and non-diabetic moms? What happens more typically with macrosomic infants of diabetic moms? Their shoulders grow big and fat, different than a normal.
shoulder dystocia is common.
Right. Because they're more common. Not common, more common. Because their shoulders grow like rugby players, right? And so the head is fine, but the shoulders can get sticky sometimes. Whereas a non-diabetic mother, it's less likely to have fat shoulders. Right? Okay. What's effects of gestational diabetes on the fetus and newborn?
Perinatal mortality is high in patients with poorly controlled diabetes. There has been a steady decline in diabetes-related perinatal deaths in the past 25 years from 18% to less than 5%. Major causes of fetal mortality are congenital anomalies, 6 to 13%, if GDM mothers have babies with congenital anomalies, as in versus non-diabetic incidence is 2 to 3%. This is the major cause of perinatal mortality in GDM, especially in the last 10 years. Congenital anomalies have replaced RDS as the highest mortality rate. CNS and cardiac abnormalities are common. Poor diabetic control during periconceptional and organogenesis results in CNS, cardiovascular, and kidney anomalies occurring between 3 and 6 weeks gestation. Ketonemia affects organogenesis. There is a relationship between HbA1c and anomalies. HbA1c more than 8.5%, incidence of anomalies is 3.3%.
HbA1c less than 8.5%. Incidence of anomalies is 3.3%. And when it goes over 8.5%, the incidence increases to what percent?
Sorry.
So when the HbA1c is normal, below 8.5%, the incidence of anomalies is 3.3%. In women with HbA1c greater than 8.5%, incidence of anomalies is 22%. That's crazy. That's an 8-fold increase.
Yeah. Control of diabetes well in advance of pregnancy is necessary to prevent anomalies. Intrauterine fetal death is more common in the last 4 weeks of pregnancy, more likely to happen in those patients with uncontrolled GDM. Fetal hypoglycemia because of fetal hyperinsulinemia, maternal hyperglycemia, placental insufficiency
are all causes of intrauterine fetal death. We have an interesting case. She's just post C-section. She had a C-section yesterday afternoon. She's GDM, the controlled sugars, no diabetes prior to pregnancy, healthy and normal otherwise, normal conception. 39 weeks. She came in almost AFI less than 5, severe oligo. Okay, and she was having small variable B cells on NST. And so baby recovered, but it would have an acceleration and then it would dip down and then come back. Acceleration and then dip down and then come back. And so I'm thinking she has less fluid, no? Fluid provides a cushion. If the baby's large and there's less water and the baby's compressing the cord, is moving and then compressing the cord, and it's causing variable deceleration and then shifts again.
Yeah, cord compression is the main.
Right. I'm thinking we should do a C-section today, right? Don't wait. But she was counseled that we can wait 2 days to do a C-section. And in my head, I'm thinking, what if a cord accident happens between now and 2 days from now, right? There's less fluid, the baby's big, she's already having a little bit of, and so the conversation was, well, cord accidents are not very common. I've never had a cord accident. They're not really, I've never really thought they were a thing. I said, why do you think healthy babies die 39 weeks? Like a cord accident, right? You can't show a cord accident on autopsy, right? Because the baby's not compressing the cord when it comes out. But it can happen if the cord gets lodged between the shoulder, especially with umbilical anomalies in gestational babies, right? They don't have as much protection from those cord compression. And so they waited 1 day only and the baby took for C-section. But it makes me nervous. If we're so nervous about intrauterine fetal demise for diabetic moms, then we should do a C-section immediately when we have concerns, not wait.
Not wait.
Right. So
I don't wait.
no, the baby was fine. Breastfeeding's fine. Everything's fine. But I was nervous.
Many deliveries, no, here.
This week? Oh, 5 so far. Now we have 2 more in labor. Okay, anyways, I digress. So, it's not to be taken lightly. When there's more complications on top of gestational diabetes, no time waste.
Better we should.
We should, for baby's well-being and mom's well-being, take the baby as soon as possible if complications are compounding. Okay, another complication for fetuses and newborns with diabetic moms.
Respiratory distress syndrome. Because of LS ratio not mature, macrosomia and subsequent severe birth trauma, that is hypoxia, etc. Neonatal hypoglycemia, this is very common, neonatal hypoglycemia. So we should get the blood sugar done and give glucose if there is hypo.
And lastly,
Neonatal hypoglycemia.
hypocalcemia.
Hypocalcemia.
Hypocalcemia can cause intrauterine fetal demise as well, right? Because your body needs calcium to make your heartbeat, right? The calcium channels?
Yeah.
Okay, I have one more question. So, what's the LS ratio?
That's the thin sphingomyelin ratio.
And so, why is it underdeveloped in diabetic infants?
No, there was something I had read about that.
The synthesis of some protein is altered by hypoglycemia.
Something like that. But I don't exactly remember now.
So that means that we have to be careful with diabetic moms. We can't just take everyone for C-section at 38 weeks because they're diabetic, because then we run the risk for respiratory distress syndrome.
Yeah,
So
that is a very important complication.
Right. So we have to keep both things in mind. We can't take the baby too early, but if complications are arising, we can't take it too late. So we have to find the sweet spot, which I think depends on provider to provider. That's why it's called the art of medicine, right? We have to do some creative thinking. Okay. What does a diabetic infant look like?
Fat, obese, adipose tissue, especially cheeks, shoulders, and increased fat in the system, increased lanugo despite gestational age. Alterations in umbilical cord may be noted. Rapid drop in GRBS post-birth. Suddenly the blood sugar can drop.
Right. So it's important to do close testing.
And many babies die like that.
If they're not appropriately monitored.
So we have to repeat blood glucose after 6 hours and all like that.
Right.
Fetal-fat placental function testing, not done for well-controlled, uncomplicated GDM. NST is first line. Some providers do CST and biophysical profile. According to me, biophysical profile is very important.
It is. CST is not done very much anymore, but biophysical profile is important, especially amniotic fluid assessment.
Amniotic fluid is most important. Now the recommendation is to complete an NST and biophysical profile bi-weekly, correct, after 36 weeks to ensure fetal well-being. This is good. Certain risk factors will mandate well-being examinations. Persistent maternal hyperglycemia, hypertension, excessive fetal growth, and postpartum pregnancy as after 42 weeks. Long-term uncontrolled diabetes on newborn long-term impairment for cerebral function due to ketonemia. Newborns born to diabetic mothers are at increased risk for obesity and diabetes onset at maturity. Then diabetic embryopathy, congenital anomalies still 2 to 3 times higher in diabetic fetuses despite improvement in management, accounts for 40% of diabetes-related perinatal deaths. Incidence 3 to 6% of infants with compared to 2% in general population, a 2 to 3-fold rise. Increased incidence in insulin-dependent patients. Etiology for the anomalies. Metabolic derangements in early pregnancy will cause disruption of organogenesis. Hyperglycemia can cause iatrogenic effects.
Okay. And what about the placenta?
Placenta in diabetic mothers. Placenta blood flow decreased with vascular problems secondary to type 1 insulin-dependent diabetes. Long-standing hypoxia and placental vascular abnormalities can occur. Pregnancy-induced hypertension is more frequent in diabetic mothers, resulting in injury to placenta.
We have some fun facts about diabetes. This is my favorite part, fun facts. You should start this with everything. Okay. What's some interesting tidbits that to keep in mind? Okay, so one important thing to keep in mind is when you're administering betamethasone for diabetic mothers for risk of preterm birth, you have to make sure they are monitored because the betamethasone steroid can cause a hyperglycemic episode.
I've never used, so
I know.
I don't have this problem.
That's why you have dull babies.
No,
Okay.
intelligent. Everybody, I used to say with Dr. Hiremat, babies are intelligent, so they would come to me for delivery.
Oh, that's a good marketing technique.
They would come because the point was the children born with me were doing very better in school than others. Yeah, that was the common this thing they gave me, and I also agree because what problem is I would monitor the pregnancy labors very well, very meticulous.
You have a low threshold for complications.
So
Nothing would be missed.
that's what. And I would post one particular postgraduate, one for each patient. I was very particular about deliveries. I wouldn't allow any slight problem. I would get very angry.
Okay, another is that women who are diabetic in pregnancy are more likely to develop pregnancy-related hypertensive disorder. So screen appropriately for PIH, preeclampsia, and chronic hypertension. That means appropriately taking vital signs. I know this is a basic thing, making sure your nurses or whoever's taking blood pressure is taking it appropriately, not just saying 120 by 80, 120 by 80, 120 by 80. Like actually.
No, but we only used to do that.
You did that?
I never allowed sisters to
Take blood pressure.
because they are very they are not at all service minded. So I never used to allow my patient.
You would take over.
And I'm surprised in a private hospital they allow.
We're on camera.
I'm surprised. I won't allow.
Okay, so what is the timing and mode of delivery for a woman with diabetes in pregnancy?
Uncontrolled gestational diabetes is not
Uncomplicated, not uncontrolled. Uncomplicated.
uncomplicated. Gestational diabetes is not an indication for early delivery or cesarean section. Early delivery is indicated if hypertension develops. Induction is not necessarily indicated, but if pregnancy crosses 40 weeks, it can be induction can be considered. Elective inductions starting at 40 weeks in patients with previous large gestational
age
infants can improve outcomes.
All right, that's all. Is there anything you want to add about gestational diabetes?
No, I can't because I'm not having a good control over my mind because since long back read all this, no? Now I'm not prepared now. So there's no proper correlation, coordination.
You have any cases that you remember that had good outcomes, bad outcomes that stuck with you in regards to diabetes?
Yes. But doctor, she delivered, there was shoulder dystocia.
She was diabetic.
She was gestational. Afterwards, she developed
Chronic.
over diabetes.
She
And
had a
that
shoulder.
dystocia she had. Then then in an attempt to remove the baby, there was fractured clavicle. Afterwards, the baby did well.
No brachial plexus injury.
No. Like that.
So shoulder dystocia can be more common in gestational diabetic moms because we talked about the fat shoulders. What are your maneuvers for shoulder dystocia? What do you do? If a mom has shoulder dystocia, how do you get the baby out?
Altering the position of the fetal head and trying to pull first to get anterior shoulder and then they lift the baby up, get the posterior shoulder.
Right. And if that doesn't work?
It has to work, otherwise what can you do?
Well, one thing I've noticed here is that doctors pull.
That's what we also do also.
But it's not evidence-based because that's how you cause brachial plexus injuries. So a midwife's perspective of shoulder dystocia, because we're taught, a lot of midwives work out of hospital, right? We don't have the equipment to do, whatever, right? And so we have to figure it out by ourselves. And so what I was taught for shoulder dystocia is shift the mom's position, get her off her back, right? Turn her to her side, maybe go hands and knees, right? Because you have time, right? It takes 10 seconds to shift the mom's position, okay? Even running the start, having a lunge position, you can try that. And sometimes baby usually comes with that because the shift in orientation of the pelvis. The other thing is suprapubic pressure. Suprapubic pressure, sometimes putting pressure on the shoulder releases that angle. And if those things don't work, then you do a manual technique maneuver where you slip your fingers under the anterior armpit and you kind of try to gently, it's all gentle, right? You gently guide that shoulder out, and then the other shoulder comes, right? Because you have to think about the diameters in the pelvis and what the pelvis is doing. Because if you just keep, here's my baby and this is going to be a head dystocia. If you just keep pulling and you're not changing anything, you're just stretching these nerves. It's not good for the baby and it's not going to potentially work. So those are the midwife tricks for shoulder dystocia.
Yeah, like that we have to try such things only because the last minute what can we do?
Nothing. You have
to try such things.
Shift the
position and then try to make the baby come out somehow.
Yeah, somehow. Right. But fundal pressure doesn't work.
The way you're asking, I'm getting scared.
Why?
I'm feeling as if I'm on duty and I'm having a case of shoulder dystocia.
Well, here, take the baby.
But I'm scared. I'm scared of that,
Why?
Because babies can die at any time.
Yeah, they can.
So that time I can't face any death, fetal death. Yeah.
Yes.
So I was getting scared, supposing such a thing had happened in my duty, like that.
You should be scared because if you feel confident.
It is confident. Here, after many such deliveries, you can get confidence.
Right, but midwives are taught to not practice out of fear because if we practice out of fear, we intervene unnecessarily. Doctors
and midwives they don't have any medical legal problems.
That's not true.
Here
That's
there's
absolutely not true.
Here there's no
not
medical.
yet because midwives are not a thing yet. In the United States, midwives have plenty of medical legal problems.
That's why they have medical legal. In the United States, even doctors have medical legal problems.
Doctors have medical legal problems
Lot,
here too.
Yeah.
Here.
Here less common because their patients are uneducated. They won't complain against a doctor so easily.
But I think the times are changing now.
Now they're changing.
I think people are getting more educated, and the internet is spoiling
Yeah.
things. And sometimes doctors don't practice based on
Never,
practice.
not sometimes. They never practice evidence.
I was trying to be kind with my words.
No, they never practice. Doctors, I will tell you, in India are horrible.
Why?
They just practice for money.
And power.
Power, no, money. So they are, that's why they are not concerned about if anything goes wrong. They should have that conscious at least, no? Humanity. They don't have that consideration. That's why I never mixed with doctors. I
Who
have
would you mix with?
students or somebody like that. Not these established doctors. No.
I see. So I don't want to be friends with doctors.
No,
Only,
ba.
only student doctors.
Students and all. At least we can teach them, something.
Right. Well, we had a lot of nice conversations today. I think we had an in-depth conversation about gestational diabetes.
Yeah, but I'm not very happy because it was not, I didn't give a confident talk. That's all.
You want to try one more time again?
We'll try later on.
Okay.
Last we'll first finish off the topics and last we'll make changes.
Okay. Sounds good. All right. See you next time.
Bye bye. Okay, now you are